Hi everyone, I'm Buwen Yao, a PhD student at University of Southern California. I'm going to introduce our study, comparison between objective and subjective sonographic evaluation of median nerve shape in the carpal tunnel during finger movement. Our study was supported by the following sources, and the study has been recently published. People who constantly have repetitive wrist or hand movement have a higher risk of developing carpal tunnel syndrome. Although the reason behind this is still unclear, it has been found that during hand movement, some people's median nerves undergo a deformation in the carpal tunnel area. So we hypothesized that the median nerve shape might be a factor related to carpal tunnel syndrome. In this study, we aim to develop a subjective categorization of the median nerve shape. There is an existing objective measurement describing median nerve shape, circularity. Circularity is calculated using the cross-sectional area and parameter of the nerve. It indicates how close the nerve's shape is to a circle. The underlying theory is that a median nerve with greater circularity is rounder. Therefore, pressure within the carpal tunnel has less impact and is not likely compressing the nerve. However, median nerves with a similar circularity can exhibit different shapes, which may correlate with different amounts of compression. For example, as shown in these three images, they all have almost the same circularity. However, they demonstrate different shapes and different amount of compression by the surrounding structures. The first one has a circularity of 0.63 and shows a rather round shape and free of compression. The second one has a circularity of 0.62 and shows a compressed flat side and a sharp angle. The third one here has a circularity of 0.63 and shows that the nerve was in a very weird shape and position. It seems that this nerve was very much compressed by the surrounding structure in the carpal tunnel. So although all three nerves have the same circularity, they definitely have different amount of compression. Therefore, they may have different possibility of developing carpal tunnel syndrome. And this type of compression information was not covered by the measurement of circularity. So we aimed to develop a subjective categorization of the nerve shape that can complete the objective measurement of circularity by providing information on nerve shape and compression. In our study, we recruited 172 asymptomatic students in our study from 2 universities. Participants who have a history with carpal tunnel release surgery or diagnosis of nerve pathology or polyneuropathy that involved the median nerve were excluded. Also, the risk with the bifid median nerve was excluded. We ended up with 167 participants with an average age of 25 and a majority of female. All participants underwent an ultrasound examination in a seated position with the shoulder adducted, elbow comfortably extended, forearm fully supinated, resting on the table, and the hand relaxed. All images were conducted with the 12 MHz linear transducer. Sonographic images were taken on both wrists at the level of pisiform to obtain the short axis views of the median nerve. 3 hand positions were used in this study. Resting, the fingers were held in a naturally relaxed, semi-extended position. Gripping motion, the participant was told to start with the fingers fully extended and slowly flex the fingers into a closed fist without any forceful squeezing. After holding the closed fist for a brief moment, the participant opened the hand to a fully extended position. To capture the median nerve during pinching, participants held the pen in their hand as if they were to write. Static images were obtained in both resting and pinching positions, and dynamic scenic clips were recorded while the participant completed the gripping motion, each lasting about 6 seconds. Images and scenic clips were analyzed using Viewpoint 6. Through an iterative process of image review and discussion, the research team developed consensus on 3 categorizations of median nerve shape. Ovoid was determined when a nerve has an oval shape with curved edges all around. An ovoid shape was not impacted by any of the surrounding structures in a non-uniform manner, making it appear free-floating. Angular nerve was defined as a nerve having at least one flat side, causing an angle or sharp distinctive change in direction when tracing the border of the nerve. Irregular was identified when a nerve is compressed by multiple structures, causing a shape that could not be clearly characterized as ovoid or angular. Circularity was calculated using the formula. A direct trace method was used to obtain this cross-sectional area and the parameter. The results showed that when the hand is in the rest position, the largest number of the subjects exhibited an ovoid median nerve. When gripping or pinching, the majority of the participants had an angular shape of the median nerve. There is a moderate shift in frequencies away from ovoid in resting to angular with grip and pinch. These figures show the comparison of cross-sectional area, parameter, and circularity among 3 shapes of nerves for dominant and non-dominant hand. The first figure shows that the cross-sectional area among different shapes were not different. The average parameter was significantly larger, and the circularity was significantly smaller for median nerves with irregular shapes as compared to angular and ovoid shapes. While the average circularity across 3 shape categories were significantly different, the range of the values overlapped across the categories. This could also be seen from this table. The ranges from the 10th percentile to the 19th percentile for the median nerve with the shape of ovoid, angular, and irregular were from about 0.5 to 0.7, and 80% of the median nerves had a circularity between 0.45 to 0.75, and they were distributed across all 3 shape categories. In conclusion, in this study, we developed a subjective categorization of median nerve shape, which is representative of the amount of compression on the nerve, and we have 2 main findings. First, we found a relationship between hand position and nerve shape. The median nerve was primarily found to be ovoid when the fingers were in a relaxed position, and the majority of the nerves having an angular shape when the fingers were moved into a full fist or pinching. Second, we found that other than nerves with a really small circularity or nerves with a really large circularity, a lot of the nerves have a middle range of circularity, and they could have different shapes and different amount of compression on them. This implies that the subjective categorization can provide additional information related to nerve compression. These results showed potential usefulness of this subjective categorization for median nerve shape, and future research could consider using these measurement techniques individually or together to identify utility within clinical diagnosis and intervention. For example, individualized care could be implemented to different people based on their individualized nerve shape. Also, longitudinal studies could examine these measurements to determine their ability to identify individuals at high risk of development of median nerve pathologies due to median nerve deformation during functional hand use. In the end, this study was done with the help of a lot of people. I want to acknowledge their contribution to this study. Thank you for listening. Please contact me with any questions that you might have, and you could check out the published paper using the citation and the link below.